Well, hey guys, and welcome to another video, Driving with Dr. Sil. For today, I might talk a little bit about the anti-psychiatry movement. I've had a couple of patients give me a hard time about psychiatry as a science, and I've read quite a bit of anti-psychiatry literature. There was a very famous or kind of controversial paper that came out last year around serotonin and the role of serotonin in mental illness and depression. And it's a controversial area, so let's talk about it. Psychiatry is an early science. Yeah, the brain is a very complicated organ. It's very hard to we just don't understand it completely, and as a result, there's a lot of areas of uncertainty, and people really want uncertainty when they're dealing with mental illness or with any disease and treatment. They want certainty, they want clarity, and I guess the job of the psychiatrist is knowing what we do know and kind of knowing what we don't know, which is it's hard to really know what we don't know by definition. And kind of with the brain, the more you learn, the more questions that arise sometimes. So I've had a lot of comments on my YouTube videos and sometimes from patients just kind of saying that psychiatry is a pseudoscience and not a real science. I think as psychiatrists or as doctors working in psychiatry, we have to really listen to the anti-psychiatry movement. Try and see what's useful. What useful feedback are we hearing versus what's not so useful? And there's been some pretty interesting anti-psychiatry kind of studies, I guess. There was the one, sorry I didn't do much reading before this. I just decided to make a video about it. But there was one study, someone in the comments will know the author. I just can't remember it off the top of my head. But I think it was the 80s where an anti-psychiatrist researcher, him and a bunch of other actors pretended to have schizophrenia and got themselves admitted, and then basically tried to discharge after a couple of days when their faked symptoms had perfectly resolved, and a lot of them couldn't discharge. And it was called, the title of the paper was called Being Sane in Insane Places. A very provocative title. It wasn't a very well-run study or anything, but it kind of goes to show that a lot of the symptoms that we depend on for our diagnoses as self-reported are subjective and are not very objectively seen externally. And if you look at the whole critical psychiatry movement and the history, it did start in the kind of taking a step back, psychiatry has a very dark past, so it makes sense that there is a critical psychiatry movement. One of them, the earliest kind of treatment of mental illness was done thousands of years ago, and that was called trephination, where they drilled, holes into people's skulls to balance the humors of bile and pus and all. I can't remember all the 5 humors, but they would drill holes into the skull to relieve people of their mental illnesses of either psychosis or depression, which didn't really work. Then came in the 1800s and early 1900s, where there was some more controversial treatments, to say the least. There was insulin coma therapy, where people were given insulin and got hypoglycemic. The insulin used up all their glucose, so they'd have really low levels of glucose. They would go into a coma, and they'd be unconscious sometimes for days, and that would treat some psychotic symptoms. It was very, very dangerous. People died from this. Then there was fever therapy, where you would give people, I can't remember the organism, maybe it was malaria or something, and it would induce a fever, and it would actually surprisingly effectively treat some people's psychosis. Later on, they found out that those people had neurosyphilis, and the fever was helping treat the syphilis in their brain, which was a bacteria destroying their neurons. And so the fever was helping attack that infection. So it was only effective for a subgroup of people. Again, lots of risks. One of the weird treatments that ended up being incredibly effective was convulsive therapy. And I said convulsive therapy, not electroconvulsive therapy, because it started off with a medicine called camphor. And it was a drug-induced convulsion, and the seizure activity would be therapeutic for psychotic and depressive and even manic symptoms. It was kind of like turning a malfunctioning computer off and on again. The issue is they didn't have very good muscle relaxant treatments or anesthetic treatments, and so people would have fractures, people wouldn't have sedation. Nowadays, it's a totally different treatment. Nowadays, you go in, you get a drip, you get you're unconscious, you have a gentle muscle relaxant, you don't shake much when you have electroconvulsive therapy, you're unconscious, you don't have a memory of the actual procedure, and you have, if needed, you can have some anxiolysis beforehand. You can't give benzos too much before ECT, obviously, because benzos are anti-convulsive, so you can't give someone diazepam just before an ECT session, obviously. Anyway, all this to say that psychiatry has a bit of a tricky past, and it was used, in dictatorships. Psychiatrists were used to call people insane, especially for political reasons. So if you disagreed with this dictator, you could be labeled insane by the psychiatrists and exiled or whatever they wanted to do. So it was used politically, and then I think from that, there came a kind of anti-psychiatry movement was born. It was also used when people kind of didn't fit the social norms. So there were many people who weren't, I'm talking now maybe towards the 60s, 70s, who didn't have a serious mental illness, but were atypical, There was a story of a guy who got involuntary treatment in the 60s. I can't remember his name, but he was... he went to university, he was a goody two-shoes, he did everything his parents wanted, and he just dropped out of university because he didn't want to do it, and he grew a beard, and he read some books, and the parents got him admitted to an asylum, and he was certified as someone with a serious mental illness, and he got involuntary treatment. And it was like, that he acted as a key person in the critical psychiatry movement to be like, this is not the role of psychiatrists, this is not a mental illness. And it begs the question, what is the role of a psychiatrist? Are we the arbiters of what is normal behavior? Are we the deciders of what is normal and abnormal? That's a big responsibility. So these are very tricky questions. I do think, I'm a psychiatry trainee, so I'm very pro-psychiatry. I think we need to be humble about what we can and can't help with. I do think we're usually the best port of call for help for a lot of mental illnesses. I worry that in, let's just call it neurotic disorders, or maybe let's just say anxiety disorders, that focusing on psychiatry as the treatment modality, focusing on medications, can distract patients or people from focusing on the psychological and psychosocial aspects of their management. So sometimes people take medicine as a way of avoiding doing psychotherapy with a psychologist because it's good enough. And that's, for me, a little bit, that's an area that we need to be really cautious of, because it's really important to do psychotherapy in those cases. So, I've kind of gone on this big tangent, but psychiatry is not perfect. It's an emerging science. A lot of the critical psychiatry movement, gives us a hard time. And I think there's a lot to learn from them. The biggest issue, the fundamental problem in psychiatry is our diagnostic system, that we do diagnoses based off subjective reports and observable patterns based on a psychiatrist's judgment, and that two psychiatrists could have two different diagnoses for the same patient. Ideally, it wouldn't be like that. We've talked about this before, but if you have a pneumonia, you can do a blood test and see the high white blood cells. You can do the blood oxygen saturations. You can see the hypoxia. You can do a chest X-ray. You can see the consolidation. You can say this is a pneumonia, and the inter-rater agreeable. The inter-rater reliability, the agreement between different diagnosticians will be very high. All the people looking at this pneumonia will say this is pneumonia because we have these objective markers. But with psychiatry, the rate of reliability is less than that because we don't have good objective tests for diagnoses. And I think we're going to find in the next 30, 50 years that a big issue in us saying things like SSRIs aren't that effective for depression and anxiety is because a huge number of, because these disorders are very heterogeneous, right? Depression, 100 people with depression may have, maybe 100 different types of depression. And some types of depression might respond to SSRIs, which, the selective serotonin reuptake inhibitors is a class of medications, which is the first line pharmacological intervention for treatment in depression. Some types of depression will respond to those, and other types of depressions won't. My suspicion is the kind of organic, randomly, unpredictably occurring depressive episodes in people who previously weren't depressed, that just came from, it seems, nowhere. I feel like those would probably respond better to SSRIs than the kind of psychosocial, long-standing dysthymic depressions that are, and when I say psychosocial, I mean like stressor-induced. Like if you've got a really tricky life full of psychosocial stresses, issues at work, issues in your relationships, issues at uni, financial stresses. If you have all these stresses and you're feeling depressed, sometimes an SSRI medication will help, but the core of the problem isn't a lack of an SSRI. You're feeling depressed because things suck. In this example, at least, I'm simplifying for the sake of this point, but so those need much more psychosocial interventions, supports. So all this to say that a lot, maybe all, but a lot of the illnesses that we treat in psychiatry are heterogeneous. A schizophrenia is not a schizophrenia is not a schizophrenia. A depression is not a depression is not a depression. They're all variable in different people, and we really have to understand the individuals in front of us and get a good formulation of the biological risks, the psychological aspects, and the developmental narrative and the social aspects too. And putting all that together, we can get like personalized treatment for this person in front of us. So, it's a bloody, really hard, complex, but super stimulating job. It's really nice because you're really trying to get to know people's stories and help people really get better. But there's a lot to learn from the anti-psychiatry movement. I mean, as a tangent, that paper that Moncrief published on serotonin last year really doesn't do much to disprove whether SSRIs and the serotonin levels in synapses influence depressive symptoms or not. And if people want me to do a kind of paper analysis on that, I can. But he did a good job to show how crap the literature around the mechanisms of medications are. So the literature doesn't do a good job of showing us how medications have changes in clinical syndromes. I agree with that. But yeah, there's just a lot. For the record, we don't know how a lot of different medications work. Even Panadol, one of the most commonly used medications in the world, has an incomplete understanding of the pharmacodynamics and kinetics. Like, it's not a fully understood mechanism of action. And that's the truth with a lot of medications. But we get criticized severely because of our history, so we have to be on our toes a bit more. Horowitz is another, I can't remember the first name, but he's another big critical psychiatry personality, and he's got a PhD, and I think he's a psychologist, or maybe he was a psychiatry trainee. But he does a bunch of interviews, he's got some really good points around, the overuse of SSRIs and the probably issues in consenting that were not thorough enough, and the risks of discontinuation syndrome. It's probably understated. So, I guess it's to say that our medications that we use in psychiatry aren't benign, and patients deserve to have informed consent when deciding on a medication. But depending on the person, it's the same with every medication. You've got to do a risk-benefit analysis. If they are suffering, and they have, there's a chance that they can get better, and the benefits of getting better outweigh the risks of having side effects from the medications and the possibility of a discontinuation syndrome. When I say discontinuation syndrome, I kind of mean like withdrawals in a way. But yeah, we just have to always make the risk-benefit analysis, and it's about the patient making the decision, right? Like, it's about promoting the patient's autonomy. Unless you are without capacity or so unwell that you're not in the world, and you might be psychotic or whatever the symptom is, unless if someone's actively psychotic, then it's different, and they might need involuntary treatment at times, at least. But if you're not, then it's all about your autonomy. It's your decision. You have to decide what treatment you want for your mental illness. It's your responsibility. It's not your fault, by the way. I always say this to patients. It's not your fault you have the mental illness, but it is your responsibility to get better and to treat it in however way you see fit. And it's our jobs to convince people, a big part of our job is psychoeducation. Yeah. All right. One last point I want to make about the anti-psychiatry movement is, what are their answers to all these problems that they're criticizing? It's all well and good to identify a problem, but it's not that helpful if you don't provide a solution. It's very easy for me to say what's wrong in the world. It's much harder for me to say what to do about it. So when I've listened to some of the critical psychiatry movement key speakers, I've been very unimpressed with their attempts at trying to solve the problems they're criticizing. If you've heard of, some interesting positions and helpful suggestions that they've got, please do let me know. But I don't know, for example, with depression, a lot of it is just acceptance that life can suck sometimes, which is totally fine for mild to moderate depression, but, totally unreasonable for someone with a catatonic depression. Like, this person hasn't eaten in a week. If you want to just kind of let them sit there and accept that life sucks, like, come on, be serious. Anyway, if you guys have any good links to interesting critical psychiatry talks, I'm really open to learning more about it. I'm a first-year psychiatrist in training, so all my positions and opinions are moldable and changeable. But I just thought I'd make that point. Like, it's a really hard problem. We're all just doing our best. And I guess, what I didn't talk about is obviously what their other big criticism is big pharma, which obviously totally influences how we prescribe it, and is a really important topic and bias for psychiatrists to be aware of. So let's talk about that in the next one. Okay. Ciao.